So without further ado, we'll get started with the first speaker. We have Dr. Claude Sader is a cardiologist who practices at the Cape Cod Healthcare Cardiovascular Centers in Hyannis and Sandwich. He attended the Lebanese University School of Medicine in Beirut, Lebanon, and completed his internal medicine residency at the Crozer-Chester Medical Center in Pennsylvania, as well as a cardiovascular disease fellowship at the Albany Medical Center in New York. He has been affiliated with Cape Cod Hospital since 2008 and is certified by the American Board of Internal Medicine and the American Board of Cardiovascular Disease. Today, Dr. Sader will discuss heart health for men and why gender matters in this regard. Without further ado, Dr. Sader, thank you. Yeah. Yeah.
Right. Yes. Hi, everybody. Thank you for having me today. Can you hear me well? All right. Before we start, I want to thank Dr. Siddhartha, Julie, for organizing this, Cape Cod Healthcare, and the Emerald crew for getting us together to have this conversation about why gender matters in cardiovascular disease. There's a lot of slides to go through. Some I want to spend a little bit more time to discuss carefully with you, and some, if we don't get caught up with too many conversations, we could probably, get through quickly. So the first thing we want to talk about is that there is some significant difference between men and women regarding the epidemiology, the pathophysiology, and the clinical manifestations of cardiovascular disease. So if you take all men and women, there is a clear preponderance of cardiovascular disease in men in general. And so the difference between men and women has always been noted in statistical evaluation of cardiovascular disease. And the difference in interaction is secondary to sex and gender. In middle-aged men, there is always more evidence of cardiovascular disease than in women. And it seems in women, there is the delay in cardiovascular disease to post-menopause. So like in the mid-60s or 70s, the women seem to have more cardiac disease at that point. Why the difference? Why is there more cardiovascular disease in middle-aged men than in women? We don't really know the exact answer, and that's kind of the short version of this 20-minute talk. And if you wanted the quick answer, here it is. We don't know. But the proof is, if you take all the risk factors out of the equation, there is still some significant difference that's not explained. So you would say, well, all men are heavy smokers. If you think of that, that might be true, but there's a lot of women who also smoke. So if you take smoking out of the equation, you still have more men with cardiovascular disease. You'd say, well, a lot of men don't take good care of their health, and they have problems with hypertension and diabetes. That's kind of true, but there's also a lot of women with hypertension and diabetes. And if you exclude diabetes and hypertension, there's still more men with cardiovascular disease than women. The difference, we think, is due to interactions between sex and gender, the biology and sociocultural processes that make men more at risk for cardiovascular disease. So being born with male sex means you have an XY chromosome compared to the XX chromosome in women, but that's not the only thing that makes you at high risk. It's not just having those two chromosomes. There is also significant sociocultural processes and significant day-to-day things in our life that makes a man more in the risk profile group. So being born with an XY chromosome is not just by itself a risk. That puts more men at risk for cardiovascular disease in the middle age period. It might be due to the fact that men with higher level of testosterone and androgen take more risk, and that's kind of the male profile. We are risk takers. Maybe even in the early human age, when we were in the caveman era, we were taking more risk. We were chasing after mammoth. We were, being chased around by saber-tooth. There was a lot of things the men had to do to comply and live and stay alive in those days. The women classically were tending for the young ones, for the babies, staying in a safe place with the families, and while the men were out hunting and dying at a very young age. So we think the average life of a caveman was somewhere between 25 and 35 years of age. That was considered the extent of their life. Now, fast forward to 2018, we're seeing a significant improvement in survival and in men's health. Before we get into the more details of why gender matters, I just thought it was a good point to bring out the social gradient, which is before we're men and women, we're all human, and there is a significant social gradient for cardiovascular disease. And this is an important thing to know in our current day, that the lower your socioeconomical status, the more at risk you are to have cardiovascular disease. Actually, the more at risk you are to have poor health also, not only from cardiovascular disease, the worse your outcome is. So there is some more social gradient to be remembered while we're talking about the difference between male gender and female gender. There's also a social gradient that's at play here. So why gender matter? Men are more frequently affected by coronary heart disease than women. These are just facts. Women have evidence of coronary heart disease 7 to 10 years later than men. And postmenopausal women after age 65 seem to have more prevalence of coronary heart disease in men. So it seems after menopause and after age 65, the women start catching up with the men in the prevalence of coronary artery disease. We think this is related to the estrogen protecting hormone in younger women. As that disappears from their system in the postmenopausal age, the protective effect of estrogen become unavailable, and coronary heart disease starts showing up. The last point on the slide is that young women have more frequently documented normal coronary arteries after a heart attack. This might be the main significant difference between young women and young men. Before menopause, if a woman has a heart attack, the odds are, if we do a heart catheterization, we're going to find that there's a significant amount of women who've had that heart attack who have normal arteries. While if we do the same procedure on men who've had heart attacks in the younger age group, most of these men have already developed the classical coronary heart disease pattern, which is blockages of the arteries by plaque, rupture of plaque, and thrombosis. In women, which is a significant proportion of coronary artery disease there too, but of a different flavor, and I'm sure it's being discussed in the women's section by Dr. Thompson, there's more coronary artery dissection, coronary artery thrombosis, vasospasm, more atypical presentations. We've gotten a very rotten deal, gentlemen. This is the CDC statistics. Heart disease still is the leading cause of death in men. 1 out of all 4 men who die will die from a coronary artery disease problem. The heart disease is the leading cause of death in men of most racial and ethnic groups. So it doesn't matter which racial or ethnic group you come from. White men have 85% chance of having coronary artery disease, 7.9 of African Americans, 6.3 of Mexican American have coronary artery disease. So if you take 100 men that you know, about 8 or 10 of them will have coronary artery disease. Worse even, half of the men who die suddenly from coronary heart disease have no previous symptoms. So they were fine until they dropped dead. And, that's pretty impressive. That's not chasing after, a saber-tooth or being hunted down in the plains in the caveman era, but it is still a very significant statistic. Between 70 to 89% of sudden cardiac events occur in men. So just looking at this slide, you can imagine the magnitude of coronary heart disease in men and why it is still the #1 cause of death as stated. Now, we talked a little bit about hormones in women, where estrogen seems to be a very positive regulating things on lipids, on inflammation, on coagulation mediators. Estrogen provokes vasodilatation of the endothelium. Thus, having estrogen in the premenopausal years for women is a protective thing. In men, the main male hormone, testosterone, is considered an androgen. And having a lot of testosterone does not seem to be a very good protective thing, as proven in some of the athletes who were using anabolic steroids, which are in the same family of drugs. Those people ended up with more cardiovascular events and cardiovascular death. But not having any testosterone or having less testosterone, which is the way aging reduces testosterone in men, seems to be also very highly related to coronary artery disease. So taking too much aggressive steroids or anabolic steroids, which increases your androgens, causes heart attack, and not having enough is also going to provoke coronary artery disease. We think the reason the estrogens protect women, all of the above mentioned, but also as they lose the estrogen protection, they seem to develop diabetes mellitus, hypertension, and obesity. At the same time that the protecting effect of the estrogen is washing out of the bodies, then between 65 and 70, there's sudden resurgence of coronary artery disease in women. This would be the same process that has been occurring in men for about 45 to 65. So for 20 years, the men equivalent have been having heart attack and having cardiac events, and until age 65, you don't see that in women until that age group. The classical risk factors, and this is kind of almost the same in men and in women. From top to bottom, high cholesterol, hypertension, diabetes, smoking, family history of coronary artery disease, obesity, and sedentary lifestyle. We don't know if any of these risk factors is the direct cause of coronary artery disease. We know all of them play a huge role in how the disease manifestation presents. But we don't know if the high cholesterol is the only problem in buildup of plaque, or if there's inflammation, irritation, autoimmune mediators that can make that happen, or if the combination of all these factors in men and women is really the kiss of death, as they say. Classical coronary artery disease, the one that most men will have, is plaque buildup in the coronary arteries over decades of multitude of risk factors, including hypercholesterolemia, diabetes, and hypertension. And then at some point, rupture of that plaque and buildup of blood clots that causes sudden onset of heart attack. The symptoms in men are called classical or typical, only because they've been described mostly in men, by doctors who happen to be men. Now, the symptoms in women we call atypical because it was also described by men physician talking about women who probably don't have that much frequent problems with the heart. But it turns out that the symptoms of classical blockages, classical plaque buildup, and chest pain from plaque buildup is the same in men and women. The atypical symptoms in women are those that happen when the arteries of the heart are clear and not blocked up, where the problem is usually microcirculation and small vessel disease. But if they have a classical buildup of plaque, the odds are the symptoms are going to be similar in most things. There are some atypical symptoms that are described in women that men don't usually have, but they need to be looked at, including jaw pain, shoulder pain, neck pain. That could be presentation for coronary artery disease, in an uncommon way in men. Another slide to look at the coronary artery disease plaque buildup. And in the main artery, the yellow in this slide is plaque and cholesterol buildup over decades of time. And then there's plaque rupture at one of the edges that brings up blood clots and platelet aggregation that causes the acute cardiac event and acute heart attack that leads to death. If you take young women with coronary artery disease and heart attack and you do a heart catheterization, these arteries would not be clogged up like this. They would have minimal plaque, if any, in them. The trouble in women is usually the microcirculation in a young age. But in postmenopausal women, after age 65, it's the same disease process, a very classical presentation. Just the protection that they have at young age, excluding all the common risk factor and just focusing on the estrogen and the testosterone, is different. We're going to talk a little bit about the engine, the heart. And I thought, what a fine example. So a fine-tuned machine, a fine-tuned engine, power, speed, responsiveness. I should buy one. So the heart is kind of like that. It's powerful, it delivers, it responds, it acts, and sometimes it has a mind of its own. So to keep the fine engine, the fine car, the fine vehicle, the fine pump working well, we really need to take care of the risk factors. All right, that was a break. Now, this is a slide that tells us how the importance of sex and gender affects cardiac disease. Sex is the genetic XY chromosomes, and gender is the environmental factors and everything else that happens to us as a young male or young adult, and then how we develop cardiac disease based on our gender sensitivities. Another slide that describes the difference between men and women. This is in women pre-menopause, there is very low risk of cardiac disease. Between 45 and 65, they get the microvascular disease. And as we go over 65, you see a high incidence of coronary artery disease. This is the obstructive blockage or plaque that we have to worry about in men in young age. I'll skip there. This is one slide that shows the discrepancy between genders in patients who are undergoing heart transplant. Most of these hearts are provided to men who have very significant cardiac disease from men, and there's very little going from men to women, focusing on the disparities in cardiovascular disease, which is again a significant problem. How you see yourself in the mirror is important because that kind of reflects who we are, and we have very few buttons that need to be pushed. And this is a George Carlin say, here's all you have to know about men and women. You could read the rest. But it's true. And this leads me to this complicated slide. It talks about sex and gender and how it affects our health. This is all into the same profile where we, instead of starting at the beginning, we always start at the end. And this might be the problem with the way we take care of our heart and our cardiovascular health. So if we take a lot of the cardiac technologies, the techniques, the recent discoveries in the last couple of 100 years, we're treating in this box. So everything we do, medications, cath, stents, open heart surgery, device, procedures, heart transplant is in this box. And we're still standing in this box trying to take care of problems that originated in many different ways far, far down the stream. The best example I have for this, and this is not, a minor issue, this is a significant cardiovascular issue. We're here trying to treat cardiac disease that has been happening over the last 20, 30, 40 years when we get to it. So it's been decades in the making when we suddenly decide, now we got to take care of this problem. We got to put a stent in here. We got to do open heart surgery. We got to do, aggressive medical therapy. And when we look back at how we got here, it's since birth, sex, gender, and other things that happen to us before we get to be an adult with a male adult with significant cardiovascular disease. The example I've given this example before in other talks. The best example here is you got batting practice and you're in the batting cage and you're standing there and the balls keep coming. Now you're hitting them out of the ballpark. You have phenomenal stents, phenomenal medicines, wonderful people, interventionalists, surgeons that take care of cardiac problems. But at the end of the day, the balls are still coming. And unless you go back and figure out how to reduce the significance of the disease by changing a lot of the things that we have to do in our society, in our current dilemma of cardiovascular problems, it will be very difficult to win the battle if we keep standing here and trying not to look at the things that led us in this direction. So on this slide, before you get into the cardiovascular active disease, we have subclinical diseases. That's the cardiovascular, peripheral disease, cerebrovascular disease, metabolic syndrome, and obesity. And before that, we start seeing increase in the biological markers. High blood pressure, kidney dysfunction, lipid profile that's off the charts. And with that in mind, now you got to go back to the diet, the physical inactivity, the drug use, the alcohol use, and all the social problems that come from it. But a human, is a complicated mix of all these factors. And if we don't get to the bottom line problems, we're going to always be treating biological markers, subclinical disease, and cardiovascular disease in the progression of this illness, and we're not going to be able to focus on why this led us here. So there is some significant changes in the body that occur, after birth when you're in the early adult ages, including social isolation, trauma, violence, abuse, work, home, and financial stress that puts the male gender with high level of androgen and testosterone into a significant, revved up type physical function and autonomic dysfunction that could lead to immunoinflammation, oxidative stress, and hormone production that could damage the endothelium. So being a man and being exposed to all of these things, you have a different reaction than if you were a woman. The hormones in women are protective, vasodilatory, and kind of try to quell the bad effects of all these problems that we have. In men, the androgens seem to have a revving up effect on these problems that lead us to cardiovascular disease. So maybe there is some explanation in the social and behavioral part that influences the hormonal stuff, that influences the androgen production that leads to the cardiovascular disease in young men. Prevention, all of these things need to be done, no matter if it's a man or a woman. Exercise, smoking cessation, heart-healthy diet, maintenance of a healthy weight, adequate blood pressure control, adequate diabetes control, and pharmacological therapy of hypercholesterolemia. My colleagues will talk about exercise a little bit later, about stress relief, about heart-healthy diet and healthy weights, which are intricate components of taking care of your heart. There's a lot of slides here that I wanted to talk about, but the focus is androgens and hormonal production in young males as we get to adolescent and young adulthood predisposes us to many cardiovascular risk factors unlike estrogens in women. And that might be the significant difference. We think it's a combination of hormonal changes in young men and social interactions and social and behavioral issues that lead to a high risk of cardiovascular disease in the early 40s and 50s in men. Just a quick note on the autonomic nervous system. We think a lot of stress, a lot of inflammation in our lives might influence us in a funny way, in a different way than just saying, oh, it's high cholesterol, it's diabetes, it's high blood pressure. There is some intricate involvement of the autonomic nervous system, and it's composed of sympathetic and parasympathetic activity, and the way that tones the heart speed and the heart rhythm is significant. And other than knowing that people have what we call heart rate variability, it's the way your heart rhythm varies or your heartbeat varies from a minute to minute. And that seems to say if the heart rate variability is high, it means your heart could adapt to a lot of different situations and have a little bit more, it's a health sign. While if your heart is stuck in a certain rhythm, in a certain steady rate, it's really not able to respond to everything. There's a lot of studies to be done in that, but this is yet just another way of imagining how we could dig into all these autonomic systems and try to come up with some medicines or some way of changing this. By the way, autonomic nervous system and heart rate variability are affected by many things, including exercise, including meditation, yoga, which some of my colleagues are going to talk about a little bit later. I left this slide, maybe we'll leave this as our last piece of conversation. This is from another talk about hypertension, but you could take hypertension out and put cholesterol in there, or you could put diabetes in there. There are many non-pharmacological interventions that allow us to prevent and treat these risk factors. Weight loss, healthy diet, reduced intake of sodium, enhanced intake of dietary potassium seem to reduce your blood pressure by 5 points, 11 points, 5 points, and you could add all these up. So if you lose some weight, have a better, healthier diet, reduce your sodium intake, and improve your potassium intake, you could reduce your blood pressure by about 25 points without a medicine. It doesn't mean you're not going to need a medicine, but you could add to the medicine effect by these many points if you did all the right things. And none of these things is difficult to do if one puts their mind to it. There might be, not always achievable, but you could always give it a try. This is, again, if you reduce alcohol consumption or you change your physical activity level a little bit, you can come up with a significant improvement in your blood pressure just by doing aerobic, dynamic resistance, isometric resistance, every day for about, 10 or 15 minutes. The difference between men and women. She's carrying a smaller weight, he's carrying a bigger weight. He's a little bit bigger, he's a little bit taller. But instead of looking at the differences in this slide, I think one would probably want to look at, they're both at the gym trying to be healthy. And maybe working together will help us make both our health is a little bit more in good shape. So this is what people think when they come to the doctor for their checkup. Every time they're in there, they're just bringing the Ferrari in for a quick checkup. It's like my waiting room. And it's done. So next time you come in for your checkup, it's not going to be like that. I wish it was.